Pak Gatot, mohon izin saya mainkan video pertama, video Indonesia.
Indonesia is the most beautiful land in the universe. The land where we were born. The nation where we grew up. So many colors that live together in peace. With a million timeless treasures. With an abundance of natural wealth. Indonesia is not just wonderful. Indonesia is a wonderland.
Kota baru dunia berbeda, berbeda bagaimanapun di Samangkara, bagaimanapun di Samangkara. Bertemu lawanlah adinda, adinda iman tidak ada rasa melayang, iman tidak ada rasa melayang. Soleram, 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 anak yang manis, janganlah dicium, sayang kalau dicium, merah pipinya. Kampuangan jauh di mata, kunwangsan sebaku liliang, takkan aja kawan-kawan alamu, sangke basuh yang suria.
bangsa Indonesia dengan ini menyatakan kemerdekaan Indonesia. Hal-hal yang mengenai pemindahan kekuasaan dan lain-lain diselenggarakan dengan cara yang sama dan dalam tempo yang sesingkat-singkatnya. Jakarta, 17 Agustus 1945, atas nama bangsa Indonesia, Soekarno, Hatta.
Belum ada.
So, Miss Irma, do you have anything to present? Maybe I will stop the video.
That's okay, Bli. I just want to remind all the participants to fill the presence form to be able to get the certificates for today's event.
Okay, thank you. And dear participants, you heard our master of ceremony what he said. So please. Yeah, or maybe you can membacakan susunan acara. I have really bad English. I'm so sorry.
Okay, Bli.
Okay, I will
So
stop.
while waiting for the event to start at 2 p.m. Jakarta time, our master of ceremony for today is Miss Pichi Luna from the Philippines. So Pichi will do the opening ceremony or to start the program, and then followed by the scientific sessions, which will be divided into two sections, the presentations and Q&A sessions. And then there will be announcement for the next CPD Asia that will be hosted by the Philippines. Yeah, sort of like that, Bikutu. And we are happy to share to you that there are around 800 participants who have registered to this event. Not
so nice, wonderful.
Yeah, I think Miss Irma signal is up and down. Miss Irma, your signal are breaking up.
Indonesia, but also from other countries. And welcome to Mr. Chun Yu. So sorry. Apparently, maybe the cyclone affects my network, Pichi, not in the Philippines.
Yeah, so Miss Irma at Kampungs right now.
Yeah.
At Gianyar ya, Miss?
Yes, I'm in the outback of Bali. Yes. Welcome, Mr. Fernando Koch from Macau.
Hello,
And
good
for-
afternoon.
Good afternoon.
Namaste, namaste all.
Yes, and we already have Mr. Chun Yuan Tu from Taiwan.
Yes. Today we have two special guests from Korea.
Yes.
Hello, Korea friends. Let
Wait,
me
I will unmute. Wait. I will still, yeah.
Yes.
Yes, everybody
Welcome,
can unmute now.
Mr. Jong Won Hee from Korea.
Okay.
And our Secretary General, Mr. Hidayat Agus Sabarudin. Good afternoon, sir.
Good afternoon, Mas Dayat.
Very good afternoon.
We also have Mr. Nelson Wan from Hong Kong. Thank you for joining us. Good afternoon, Mr. Sibilai Intaseng from Laos.
Yes, good afternoon, everyone.
Good afternoon. Good afternoon.
Good afternoon, Ms. Sophia Lee from Cambodia.
Good afternoon, all president
Very good
and friend.
afternoon.
Nice to meet you.
Thank you for joining us.
Thank you.
Intro video is very fine. It's a wonderful
Thank
photography,
you.
videography.
Yeah, I still mute the sound.
Malah.
Ya udah pinter ya.
Good afternoon, our guest, Mr. Jong Won Hee from CBRTA.
Hello, nice to meet you.
Nice to meet you. Thank you for joining us today.
So,
And Miss Irma, I will test our national anthem
Yes, sure.
and our PARI march. Is it accepted? Yeah.
Yes, all good. Yes.
Thank you. And now is PARI. Okay. Good, yeah?
Good.
Thank you. And I will test the video of the presenter. This is the first one. And this is the second one. And then this is the third. Clear, yeah?
Clear.
Hello, good evening, everyone.
So nice and interesting topics are covered today. Good to see.
Thank you, Mr. Salva.
Yeah. Thank you, sir.
It's a pleasure to meet you all. Elias today is full packed. All the members are actively on the screen now. Happy to see you all.
Thank you.
Okay, please, Miss Irma, we can start.
Okay, please excuse me, ladies and gentlemen, before we start the program, we will play the national anthem of Indonesia and the official song of PARI. So for Indonesian participants, please sit straight in a respectful position. Thank you. Well, ladies and gentlemen, the national anthem has concluded and you can assume to a relaxed position. Thank you. And maybe we can start the program to our MC, Pichi.
Yes, thank you, Putu. Irma. Hi, everyone from Asia and all over the world. This is Asia CPD, the online continuing professional development platform for Asian Radiologic Technology Societies. And hosting the 25th CPD Asia is no other than the Perhimpunan Radiographers Indonesia or Indonesian Society of Radiographers, PARI. I am Peachy Luna and I am your CPD Asia program host. To everyone, we are live streaming on YouTube and please search PARI and VART channels so you can join us live or watch a replay. This CPD Asia is highly supported and graced by member societies, presidents, officers, and their representatives. Let us greet and welcome President of Macau Radiological Technologists Association, MRTA, President Fernando Koch.
Hello, good evening, everyone. I am Fernando. Thank you.
Attending for President of Vietnam Association of Radiological Technologists, VART, for President Taiwan Loc is the VART Secretary General, Mr. Liu Thri Dung. We also have the President of Hong Kong Radiographers Association, HKRA, President Wan Shu Bun Nelson.
Hello, everyone. Nice to meet you.
Thank you, President Nelson. Now we have the President of the Taiwan Association of Medical Radiation Technologists, TAMRT, President Chun Yuan Tu.
Hello, everyone. Nice to meet you. Thank you.
We also have the President of the Indian Society of Radiographers and Technologists, ISRT, President Selva Kumar.
Very good afternoon to all. Warm welcome and greetings from India to all. Happy to meet you all.
Thank you, President Selva Kumar. We also have President Sophie Lee of the Association of Cambodian Radiological Technologists.
Hello, our President and friend, greeting from Cambodia. Thank you so much.
And greetings to President of Malaysian Society of Radiographers, MSR, President Sawal Marsait. We also have greetings for President of Philippine Association of Radiologic Technologists, Rolando Benares, and for Singapore Society of Radiographers, SSR President Denise Chung. We also would like to greet our friends and radiographers from Myanmar Society of Medical Radiation Technologists, and from the Vice President of Palestinian Association of Medical Radiation Technologists, Muhammad Abdal Ghani. And also attending with us are our special invited panelists. We have from Korea, CBRTA, the President Won Hee-jung. Welcome, President Won Hee-jung. Are you here?
Hello, all the members. I'm Ori-jung, the President of CBRTA, and so glad to meet you. Thanks for inviting me.
Yes, thank you, dear President. We also have from CBRTA, the Education Director, Ki Baek Lee. And representing Lao is Mr. C.B. Lay.
Hello, everyone. Nice to meet you. Thank you.
Thank you very much, dear presidents, officers, representatives, and our invited panelists. They will be joining us later again during the Q&A session. So before we start the program, may I humbly request all presidents and officers, the representatives, along with the PARI host officers and moderators and speakers to please open your camera shortly for a photo session.
Okay, I will take the picture. 1, 2, 3, 4. Okay.
Yes, thank you very much, Putu Adi Susanta. So let's move on to the most exciting part. To formally start the program and give us the opening speech and welcome message, please welcome Mr. Gatot Santosa, the head of the International Affairs of the Indian Society of Radiographers, to speak on behalf of President Gek Sugianto of Perhimpunan Radiographer Indonesia. Again, welcome, Sir Gatot Santosa.
Thank you, Bichi. So just want to make sure that everyone can see my screen. Bu Irma, you can see my screen?
Yes, clearly,
Yes.
Mr. Gatot.
Oh, yeah.
Okay. So good afternoon, everyone, dear all presidents, delegates, speakers, and colleagues. On behalf of Indonesian Society of Radiographers and President Sugianto, it's my pleasure to welcome you to the 25th of CPD ASIA, which is the 4th time hosted by the Indonesian Society of Indonesia. And we are thrilled to have every one of you to joining us today. Before I start opening, I would like to send our sympathy and to the victims that super tycoons in Philippines. Wish you all stay safe there, and we pray for the swift recovery to those all affected by the storm. The second, we would like to thank you to Ari Dwijayanti and Laila Nurdevianti, radiographers from the National Cardiac Center Harapan Kita, Jakarta, will sharing an expertise in cardiac MR and cardiac perfusions with the nuclear MR and nuclear medicines. And special thanks to Dr. Mira, consultant radiologist from Siloam, Bali, which still recover from your sick, doctor. Thank you very much. But you still continue commit to share the knowledge and expertise. And we wish you get well soon, Dr. Mira, soon as possible. So the topic today event is cardiac imaging. This is very important topic due to the dynamic of nature, clinical significance, technology advancements, and also the potential of interdisciplinary collaborations and education's values. So just recently, the Ministry of Health of Indonesia having the roadmap how we are addressing the big three challenging for the non-communicable disease, which is we have the homework here to address the cardiovascular and stroke disease and the cancer. So that is what's happened today in our country. And the big three of the death cause, which is more than 85% is coming from the stroke, cardiovascular, and cancer. And the Ministry of Health is already having the clear roadmap how we addressing these situations from the primary care transformations, the secondary, and also the third priority with healthcare system resilience transformations. And today we will sharing an expertise how we are Indonesian Society of Radiographers and also from the radiologist point of view, we stand and fight to address from the cardiovascular disease. This CPD webinar provides its ideal platform to discuss from the technology point of view, techniques and clinical implication on the cardiac imaging. And we hope this topic interesting and give you valuable insight to share among us. With the total participants today who registered from the domestic is 607 and the 36 participants from other country. And we would like also to thank you to our sponsor and Indonesian's team who's supporting this. And I hope through the CPDASIA platform, we can continue exchange the idea, contribute to the improvement of the patient's care and radiological services in our respective country. We wish this event will serve as a catalyst for professional growth, network, and collaborations among all participants. Once again, thank you for joining us, everyone. Please enjoy the program and thank you. Come back to you.
Yes, thank you so much, Sir Gatot Santosa, for giving us that interesting information regards the Indonesia and the works of the government for healthcare and the works of PARI in response to the demands of the changes in the healthcare. So again, thank you, Sir Gatot, for that warm welcome and opening speech. So to begin now, the session program, allow me to briefly introduce our program moderator. She is Ms. Putu Irma Wulandari. Putu Irma has graduated master's degree in diagnostic radiography at University of Sydney and now working as a teaching staff at Radio Diagnostic and Radiotherapy Academy in Bali, Indonesia. Our program moderator, please welcome Ms. Putu Irma Wulandari.
Thank you, Pichi. Hello, everyone. Welcome again to the 25th CPD Asia. And this is an honor for us to host the CPD Asia for the 4th time. And my name is Irma. I'll guide you to the scientific program of CPD Asia. And these sessions will be divided into 2 sections. The first one is the presentations and followed by the Q&A session. And before we move on to the presentations, I would like to introduce you to our speakers. As today's theme is cardiac imaging, we've provided you with outstanding experts to talk about the latest advancement in technologies, techniques, and clinical assessments of cardiac imaging. So please welcome our first speaker, is Ms. Ari Dwi Jayanti. Ms. Ari, can you hear me?
Yes, I can hear you, Mrs. Irma.
Yes,
Good afternoon, everyone. Nice to meet you all.
Thank you for joining us today, Ms. Ari. So, ladies and gentlemen, Ms. Ari has completed her diploma degree in radiography in 2003 before she continues her education in Bachelor of Public Health in 2014 and Diploma 4 or Bachelor degree in Radiologic Imaging Technologies in 2020. She is now working as a radiographer at National Cardiac Center of Harapan Kita Hospital, Jakarta. She's been practicing with a broad range of imaging modalities such as CT scan, MR, nuclear medicine, and interventional radiology. And today, Ms. Ari will be talking about cardiac MR perfusion. Is that right, Ms. Ari?
Yes. Yes, Mrs. Irma.
Okay, yes. Thank you again for joining us. I'll be back to you later. And our second speaker is Ms. Laila Nur Devianti, or usually called Ibu Devi or Miss Devi. Miss Devi, can you hear me?
Yes, Mrs. Irma. Good evening, everyone.
Okay. So, ladies and gentlemen, Miss Devi also completed her diploma degree in radiography in 2001, and she works at the National Cardiac Center of Harapan Kita Hospital, Jakarta. And today she will be talking about stress perfusion imaging in nuclear medicine. Is that right?
Right,
Ibu Devi,
Ms.
Miss Devi?
Right, Ms. Irma. Thank you.
Thanks again for joining us. I'll be back to you later. And last but not least, we also invited a very outstanding expert. She is Dr. Mila Yuniarti. Hello, good afternoon, Dr. Mila.
Hello, Ms. Irma. Good
Thank
afternoon.
you for joining us today. I hope you are well.
Yeah, thank you.
So, ladies and gentlemen, Dr. Mira earned her medical degree in 2003, and then she took specialty in radiology and completed in 2009. And then she took fellowship in thoracic imaging in 2017. Dr. Mira is now working as a consultant radiologist at Siloam Hospital Denpasar, Bali. Is that right, Dr. Mira? Okay, thanks again for joining us today, Dr. Mira.
Thank you.
Okay, so ladies and gentlemen, if you have any questions related to the topic today, please post your questions to the Pigeonhole applications, and you can access it through your chat box. And without wasting much more time, let us watch the first presentations from Miss Ari Dwi Jayanti about cardiac MR perfusions. So please enjoy, everyone.
Thank you very much. Good evening to all participants of CPD ASIA. Let me introduce myself. My name is Ari Dwi Jayanti, and I am a radiographer at the National Cardiovascular Center Hospital Harapan Kita, Jakarta, Indonesia. I'd like to thank CPD ASIA Committee for giving me trust and opportunity to get involved in this program, to share knowledge and experience about how we do cardiac MR perfusion. For your information, our hospital to be a national referral center for cases of heart disease, both coronary heart disease and congenital heart disease as well. I will start to share my screen. Thank you for waiting. This is infographic from World Heart Federation. They tell us the cardiovascular disease to be the world's #1 killer. We can see that not less than 18.6 million deaths every year is caused by CVD. And what about in Indonesia? In Indonesia, coronary heart disease to be #1 killer with 122 people of death per 100,000 of population. And according to report from BPJS, or Social Heart Insurance Administration in Indonesia, heart disease became one of the diseases that spend more than 39.8 trillion rupiah on health insurance funds. To reduce the number of deaths from heart disease, it needs to be supported by adequate examination facilities, one of which is an MRI of the cardiac or cardiac MR. What is CMR? CMR is cardiac magnetic resonance imaging or cardiac MRI perfusion, or also known as test CMR perfusion, is a clinical magnetic resonance imaging test performed on patients with known or suspected coronary artery disease or else, to determine if there are perfusion defects in the myocardium of the left ventricle that are caused by narrowing of one or more of the coronary artery. Cardiac MR perfusion is used to view, to evaluate, and to assess cardiovascular morphology, ventricular function, myocardial perfusion, tissue characterization, and flow quantification of the heart. If we want to do CMR perfusion, firstly, we have to understand about the blood circulation. We have to know blood flow out of aortic and pulmonary and part of the heart chambers. Where is the place of the atria and ventricle? Where is the place of mitral valve and tricuspid valve? And of course, we have to know the layers of the heart and anything which has relation to heart disease. And the other thing that which is important in CMR is ECG, which stands for electrocardiography, because almost all of the sequences for signal and function performed during diastolic phase. So, because of that reason, every radiographer who wants to do CMR, it's better to understand how to read ECG in a simple way. Before we are going to the next topic, there are 17 myocardial segments on a bullseye display according to American Heart Association to describe coronary territory and short axis view of the left ventricle. As you can see on the screen, the purple color represent LED area, the pink color represent RCA area, and the green color is represent LCX area. This is the equipment that we use or we need for cardiac MR perfusion. All the equipment that will be used must be sure for MRI safe. Especially for cardiac MR perfusion, there are additional tools that are used, such as blood pressure and heart rate monitor and searing pump for adenosine. As you can see on the screen, anesthesia machine, portable ventilator, and ergo cycle also need in some condition. These are some of the sequences that used in cardiac MR perfusion. Each sequence is named for a different brand of MRI machine, also has different sequences name. Even so, there are sequences named that are commonly used, such as black blood or dark blood, SSFP, and others. And these are several medical devices that fall into the conditional category for MRI examination, such as occluder devices, prosthetic valve, corner stent, and so on. For cardiac MR, there are several preparations that must be made by patients, such as fasting at least 4 hours before examination. Although it is not mandatory, but it should be done to prevent vomiting when contrast media is administered into the patient's body. Stop consuming food and drink that contains caffeine, as well as drugs that can interfere with adenosine. Because we use contrast media in this exam, patients also need to check the renal function. Contrast media that used in cardiac MR perfusion was KBCA or gadolinium-based contrast agent. And this is the dose of the contrast media that we use on CMR perfusion. It is important part to explain to the patient about the examination that will be held, about the MRI tube itself that is long and relatively narrow, and the basic principle of the examination that is no radiation in MRR, and then approximate duration of the examination that a little bit too long for a patient is almost 45 until 60 minutes, depend on the cooperative of the patient. We also need to explain what should and what shouldn't patient do during the examination. Like patient should have to follow the instruction and shouldn't have to move much at this examination. Through explanation will increase patient compliance, improve image quality, and shorten the examination time. The following is the preparation process of cardiac MR perfusion. Before the examination, the assessment will be held by a doctor to find out the medical history and indication of the examination. After it declared safe, patient fills out informed consent. After that, we record the ECG and then an IV line is placed on the left and right hand for adenosine and contrast media. At the examination room, patient position supine, head first, and ECG placed on patient chest. Put the respiratory belt at belly or lower ribs. Place coil on chest area and BP cuff on the leg area to monitor heart rate and pressure. Cardiac MR perfusion protocol may be differ from one hospital to another, and this is a protocol that we use at Harapan Kita Hospital. it takes around 45 until 60 minutes. It also depends on the condition of the patient. As you can see on the screen, there is stress and or rest perfusion. Decision about stress or rest perfusion was made by the doctor after doing assessment before the examination. For stress perfusion, pharmacological stress agent that used in Harapan Kita Hospital is adenosine. There are several contraindications for adenosine stress cardiac MR, and is known during anamnesis. Adenosine dose was given based on patient weight. Adenosine is vasodilator and has very short half-life, so it's considered more severe than other pharmacology stress agents. We start the examination by taking 3 plain localizer sequences. And then we continue with morphology sequences by black blood. The purpose of these sequences is to assessment anatomy of the heart and mediastinum, as well as thoracic aorta and great vessel. It's done in axial, coronal, and sagittal view. With these sequences, we can also doing short scanning if there is additional indication like kyst, effusive pleura, and FC pericard. Next scene is function or scene sequences with SSFP sequences or single shot free precision with 2-chamber, 4-chamber, 3-chamber or LBOT, and then short axis. All of the scene sequences purpose is evaluation of the cardiac wall motion, ventricular volume, ventricular mass, valvular function, and movement of blood through the heart. And we can continue with edema scan. Edema scan was by T2 STIR or T2 DIR sequence. The purpose of the sequence is to look over myocardial edema from myocarditis or active inflammatory disease. We also made a mapping scan. It is T1 mapping and T2 mapping. T1 mapping was taken to look over myocardial early edema or microedema that can be seen from edema scan. T1 mapping used to find early fibrosis process. Key-flow sequences is additional sequences that can be done or not depend on condition of the patient. As we can see in this patient, from the 4-chamber view, we can see that this patient have a severe or moderate severe mitral regurgitation. So we do additional sequences that is key flow for pulmonary artery and for aorta. And then the perfusion scan sequences. Perfusion scan sequences was held after 3-minute adenosine through inside the body, or after the heart rate of the patient was increased 10% from the heart rate at the beginning. At the perfusion scan, we also put contrast media to the patient. After the perfusion, we insert the second contrast media, and we have to wait around 5 minutes to make these sequences. This is a loop locker sequences. Loop locker purpose is to find the optimized TI prep time for applying on LGE. The LGE sequences or delay enhancement was done. The purpose of the sequences is to detection of myocardial changes such as scar, edema, necrosis, and fibrosis. And it also can to evaluate the viability. It's done in 2-chamber, 4-chamber, 3-chamber, and short axis position. And this is the result of the delay enhancement. At the short axis, we can see that around the bull's eye, there is a white part at the LED area. Also at the vertical long axis or 2-chamber, there is a white part. And then at the horizontal long axis or the 4-chamber, we can see also the white part. It's called scars. After the examination done, the nurse will detach IV line and patient will be observed for the last time to see if there is any effect after examination. The conclusion of my presentation is poor images leads to poor diagnostic accuracy. Good images is a result from good preparation, good planning technique, and cooperation from the patient. So that was my last screen. I will end up my presentation. And thank you so much for your attention.
Okay, Ms. Shima, that was the last presentation.
Yes, thank you for the outstanding presentations, Ms. Ari. So, ladies and gentlemen, Ms. Ari has emphasized all aspects of cardiac MR perfusions, including its significance, patients and scanning preparations, techniques, and sequences as well, image evaluations, and post-procedure care. Thank you so much for your presentation, Ms. Ari. And ladies and gentlemen, don't forget, if you have any questions related to this topic, you can post your questions through the Pigeonhole applications. You can access it through the chat box. And let's move on to the second presentations. It will be delivered by Ms. Laila Nur Devianti about stress perfusion imaging in nuclear medicine. So please enjoy, ladies and gentlemen.
Good evening. Thank you, Ms. Irma. First of all, I would like to thank to the committee who has given me the opportunity and the trust to be the speaker at 25th CPD Asia. At this program, I will like to present about stress perfusion imaging in nuclear medicine, actually same as myocardial perfusion imaging. Let me share my screen. As cardiovascular disease are being the world's #1 killer according to World Heart Federation, the doctor look for the best way to decrease by improve livability of the patient with CAD. Patient with CAD or coronary artery disease maybe needs some evaluation. The need of intervention with CABG, coronary stent implant in order to increase the blood perfusion to the myocard, or by pharmacological. The doctor needs good assessment to choose the right therapy for the patient with CAD, whether it is with CT coroner, MRI, or MPI. The outline for today's presentation are the definition of myocardial perfusion imaging, indication, and the contraindication. And then what instrument or material we need for the MPI study. The most step that we have to do for MPI study are the workflow on doing this. It will produce the good result and the doctor can make a good conclusion for the patient therapy. Myocardial perfusion imaging is a non-invasive imaging test that shows how well blood flows through heart muscle and can be taken with two steps, stress test and rest test. For stress test could be exercise or adenosine. Exercise stress test. Exercise stress test is the myocardial perfusion imaging that taken with ergocycle or treadmill. It is the preferred stress modality in patients who are able to exercise to an adequate workload. Adenosine stress test is the myocardial perfusion imaging that taken with adenosine. The indication or why we need MPI study are MPI that were useful to detect of CAD in the following patient with intermediate patient probability of CAD based on age, gender, and symptom, and patient with high risk factor for CAD. To have risk stratification of myocardial infarction, whether it is mild, moderate, or severe. Risk stratification of patient with chronic stable CAD into low risk category that can be managed medically or into a high risk category that should be considered for coronary revascularization. Risk stratification before non-cardiac surgery in patients with known CAD or those with high risk for CAD. And then to evaluate the efficacy of therapeutic intervention, anti-ischemic drug therapy or with coronary revascularization. Before bypass coronary surgery, they need MPI because the doctor wants to find out whether it is useful or not if they make revascularization to myocard area with total occlusion of coronary artery. The contraindication of MPI study are patients with left main coronary artery stenosis, moderate aortic stenosis, and significant tachycardia or bradycardia. And there are some limitations on doing this study, such as exercise stress testing has a lower diagnostic value in patients who cannot achieve an adequate heart rate and blood pressure response due to a non-cardiac physical limitation with pulmonary, peripheral vascular, or musculoskeletal abnormalities or due to lack of motivation. The second one of the limitation of MPI, if it's happened, this patient should be considered for pharmacologic stress with myocardial perfusion imaging. Patient with osteoarthritis can do the exercise stress testing with ergocycle or treadmill. It's considered to have MPI with pharmacologic stress test. And patient with asthma cannot do stress test too, but they can do the stress test with adenosine. The instrument we need to do the study are, first, the most important is gamma camera. In continuous ECG monitoring, it is useful to decide the right time when we have to delivering the radiopharmaceutical or the tracer. We need searing pump that can set 100 until 500 mm in velocity to deliver adenosine to the patient in 6 minutes. Post-processing workstation is also important to process the raw data, so we can have good results that very useful to diagnose whether it is bad perfusion or good perfusion at the myocard because of the abnormality of the coronary. The tracer that we need to do MPI study are TC99M with MyoView or MIBI. Last but not least, we need adenosine for adenosine stress test. This is the workflow. I think skip for this. Okay, this is the next slide. The workflow for the MPI study. After we prepare for the patient, instrument and material, the doctor also do the assessment to the patient. The doctor decide whether it is in stress test and rest test or just rest test. And then the stress will be due with ergocycle or adenosine. When the stress test or rest has been done, 15 until 45 minutes after injection, the scan will take. It will take approximately 20 to 30 minutes scan time. Then the radiographer process the raw data to have good data so the doctor can make a good diagnosis for the patient. There are some preparation that must be taken by the patient since 2 days before the examination, such as 2 days before the study stop beta blocker is a must. If the patient forgot to stop, it will affect on the value of maximum heart rate they have to achieve at the ergo cycle stress test. And then fasting for 12 hours before the study. Last, bring the result of the previous test. The procedure of the ergo cycle test is first, educate the patient about the procedure. The patient must know how to use the ergo cycle and the process of cycling the ergo cycle on the process of exercise. Nurse make the IV access with ABOCAT and connect with heparin cap or three-way with extension. It still can be used for rest test. So after the stress test has been finished, no need for the nurse to dispatch the ABOCAT. Don't forget to check the patency with NaCl 0.9% around 5 milli. Place the 12 lead ECG to the patient that connect to the monitor hemodynamic and record every 2 minutes at the process of ergo cycle stress test. Place the continuous peak manometer, set every 2 minutes to measure, and then start the exercise test. The exercise use intensity from 0 to 100 watt. It will be raised every 2 minutes in multiple in 25 watt. Don't forget to record the ECG or hemodynamic of the patient during the exercise. It is nurse responsibility. The nurse will be inject when the nurse will be in not the nurse, I means the doctor. The doctor inject the tracer when the maximum heart rate are achieved or when we see the ST elevation, ST depression on the ECG diagram, or when the patient is unable to continue the exercise, and the dose of the tracer around 5 to 8 millicurie. Then slowly ask the patient decrease cycling the ergo cycle until stop. After that, patient wait for the scan around 15 to 45 minutes at the post-injection waiting room, and don't forget to tell the patient that they have to consumption of high-fat food. Another way to have stress test is adenosine stress test. First, when we are going to do adenosine stress test, first we have to educate the patient about the procedure. The patient supine, and then nurse make the EV access with ABOCAT and connect with heparin cap or three-way with extension. It can be used for the rest test. So after the stress test has finished, no need for the nurse to dispatch the ABOCAT. And don't forget to check the patency with NaCl 0.9% around 5 milli. Connect the IV line to syringe pump with adenosine in it. And then place the 12 lead ECG to the patient that connect to the monitor hemodynamic and record every 2 minutes at the process of ergo cycle stress test. Oh, I'm sorry, I mean the adenosine stress test. Place the continuous peak manometer, set every 2 minutes, and then start the adenosine stress test. The dose of adenosine depends on weight of the patient. Adenosine will deliver through IV in 6 minutes, and the tracer carry out at 3rd minute with the dose around 5 to 8 millicurie. Adenosine stress test finished after all of the adenosine was delivered to the patient. After the patient After that, patient wait for the scan around 15 to 45 minutes at the post-injection waiting room. And don't forget to tell the patient that they have to consumption of high-fat food. This is the slide of diagram of adenosine protocol. I have explained it at the previous slide. We see that the number 0, there is the numbers from 0 to 6. It means the adenosine delivered to the patient in 6 minutes. And at the 3rd minute, the tracer delivered to the patient through IV. This is a diagram of time to inject the tracer and time to scan. I have explained it at the previous slide and showing the time to have rest test. It is 2 hours after the tracer. Wait, I will show you. Okay, I will show you that after the scan will take there is 30 minutes and until 60 minutes after rest injection, the patient waiting at the room of post injection, and then take the scan after 30 minutes, and the scan approximately 20 minutes. After we process the raw data using software, the image view, we will have short axis view, vertical long axis view, and horizontal long axis. We will have slices for every view. At this slide, we see the bright color of myocard. It means the perfusion to the myocard is very good. So when the color not bright, even dark or black, it means there is a defect at myocard at certain segment. So we must know the rule of segmentation of myocard. At this slide, we can see clearly. At the left side, we see the myocard in bright color in every view. And the right color side, we see the myocard with a lot of defect. Some segment in dark color and some segment loss of color. Okay, according to this myocardial segment, we can see at which area that have a defect and which coronary with abnormalities perfusion to myocard. When the defect at the yellow color, it means there is a problem of perfusion at left anterior descending artery. And when the defect at the red color, it means there is a problem of perfusion of right coronary artery. When the defect at the yellow color, it means there is a problem of perfusion of left circumflex artery. With the software at Nuclear Medicine to process raw data, we also have the heart pump visualization. It is very useful to see which is the normal heart pump and which is in abnormal heart pump, or at which segment of myocard have an abnormal on pumping of the blood. Okay, now we have to the conclusion. First, myocardial perfusion imaging is a non-invasive imaging test that shows how well blood flows through heart muscle. Second, myocard perfusion imaging can diagnose coronary artery disease. And the last, myocard perfusion imaging result the viability of myocardium, and it's useful for decide best therapy to the patient with coronary artery disease to improve their ability of life. Okay, thank you. That's my share. Maybe if you have some question, you can type your question at chat column. Okay, thank you. And time I will give to Miss Irma. And I will stop share screen.
Okay, thank you for your great presentation, Ms. Devi. And ladies and gentlemen, Ms. Devi has emphasized on considerations when performing myocardial perfusion in nuclear medicines, especially its significance, instrumentations that we use, the preparation, imaging technique, and image evaluations. Thank you for the outstanding presentation, Ms. Devi. And ladies and gentlemen, if you have any questions related to the presentations, you can post your questions again through the Pigeonhole applications. You can access it through the chat box. Okay. And now for the last presentations, we have presentations from Dr. Mira Yuniarti. We'll be talking about the image assessment of cardiac MR perfusions. So ladies and gentlemen, please enjoy.
Hello, good evening, everyone. Thank you for your introduction. First of all, I want to say thank you to the committee and to all the participants on this meeting. I'm honored to be given this chance to share my experience in cardiac MRI. Let me share my screen. Okay, the title of my presentation is Cardiac MRI Assessment of Myocardial Perfusion. Introduction. As we know, coronary artery disease is the most common cause of mortality and morbidity around the globe. Assessment of myocardial perfusion to diagnose ischemia is commonly performed in symptomatic patients prior to referral for cardiac catheterization. CMR is increasingly used to evaluate rest and stress perfusion and to identify myocardial ischemia and infarct with a high degree of accuracy. Stress CMR is a non-invasive one-stop assessment of myocardial ischemia, myocardial viability, and cardiac function. Limitation in myocardial perfusion analysis by CMR are lack of availability of CMR imaging expertise in many centers, patient-related such as obesity, claustrophobia, poor gating, motion artifacts, contraindication to use of vasodilator agents, and gadolinium contrast agents. Myocardial perfusion on resting coronary blood flow increases with exercise or other stress. However, significant stenosis coronary blood flow cannot increase with stress, and an inducible perfusion defect apparent in the relevant coronary artery territory. Perfusion CMR can identify this perfusion defect and correlation with myocardial scintigraphy. CMR allows improved resolution with no ionizing radiation. How to do stress perfusion? We choose adenosine because adenosine is the most commonly used vasodilator stress agent in clinical practice. Patient must avoid caffeine-containing products such as coffee, tea, and chocolate for 24 hours beforehand. The first one, an infusion of intravenous adenosine with dose 140 microgram per kg per minute for 3 minutes. After that, we give a bolus of intravenous gadolinium, dose 0.1 millimole per kg at a rate of 7 milliliter per second, followed by 15 milliliter of normal saline at the same rate. Ventricular short axis lysis, including basal, up, mid, and apex, offer the first cardiac cycles of this first pass perfusion. Image acquisition is over 60 seconds and patients are instructed to breathe gently when needed. Rest perfusion. Resting perfusion is delayed for 10 until 20 minutes after stress perfusion. This time is to reduce gadolinium levels in myocardium. We use ECG-gated T1 weighted images are obtained using gradient echo, hybrid gradient echo planar, or steady-state free precision imaging. Perform using the same dose and rates of gadolinium and saline as those for stress but without the adenosine. Consider abnormal if upon gadolinium and sun administration, a low signal of T1 weighted image is detected in a myocardial segment, which persists for a period of at least 5 heartbeats. This is vasodilator stress cardiac MRI protocol. The first 10 minutes, we do Scott imaging, Sina imaging except short axis SSFP 1 stack, and then continue with adenosine infusion for 3 minutes, continues with IV gadolinium contrast injection, then we do dynamic stress perfusion. Before we do dynamic stress perfusion, we can make a short axis Sina stack imaging, and after 10 minutes, we inject gadolinium contrast and do the rest perfusion. And we have time 5 minutes before we doing LG imaging. So in this additional needed imaging like LVOT, RVOT, or maybe flow imaging we can do here. This is TMR sequence of myocardial perfusion. The first one, contrast enters the right ventricle and then left ventricle and then perfuse all the myocardium. This is first pass perfusion signal intensity. We can see the normal myocardium is perfuse all the myocardium, but in ischemic myocardium is lower perfusion and decrease of T1 signal if we compare with the normal myocardium. This case is example for 3-vessel disease. We can see the perfusion defect almost all the LV myocardium except on the anteroseptal segment. And after rest perfusion, the myocardium is back to normal in the same slice. This patient has perfusion defect in the anteroseptal and anterior segment of basal LV, and then on rest perfusion, the myocardium back to normal perfuse. On LGE, we can see no net gadolinium enhancement, and on coronary angiography, we can see occlusion in the mid LED. This is a patient with microvascular obstruction. We can see the hypoperfusion defect in almost all of the left ventricular myocardium and back to normal perfusion on rest perfusion and no lead gadolinium enhancement. But we can see in the coronary angiography no obstruction or stenosis in the coronary artery. So that means it's because of the microvascular obstruction. On this protocol, we also do SINA and lead gadolinium enhancement or viability imaging. On SINA, we can assess the left and right ventricular systolic function, and on LGE is the best technique presently available for locating and sizing myocardial infarct. The ideal CMR technique for LGE with the use of inversion recovery or TI to null normal myocardium. This is LGE mid-ventricular short axis view on the appearance of the myocardium when the inversion time is set. A is too short, B is too long, and C is correctly. The report of perfusion CMR include: 1 is anatomical description of the perfusion defects, follow the 17 segment model. 2. Correlation of this defect with the pattern of percentage of LGE. 3. Description of viability. 4. Quantification of ventricular function. On late gadolinium enhancement, we have to percentage the transmurality of the myocardial infarct. We categorize normal, and then 1 until 25%, and then 25 until 50%, then 51 until 70%, and more than 75%. So if the myocardial infarct is less than 50%, that means the myocardium is still viable. But if more than 75%, the myocardium is non-viable. This is the case. We can see before stent, there is abnormal wall motion on the septal, anteroseptal segment of the LP. We can see the hypokinetic of the myocardium and no enhancement on LGE. After stent, the myocardium can normokinetic. And the second patient, we can see before stent, there is abnormal wall motion in the basal anteroseptal. On the LGE, we can see transmural enhancement more than 75%. And after stent, the myocardium still hypokinetic. So that means if we see the stenosis or the scar tissue is less normal or no myocardial infarct or less than 50% is candidate for revascularization. It could be PCI or CABG. Don't forget about dark rim artifacts on myocardial perfusion. Normally lasts for a few heartbeats and very temporary, and normally we can see dark rim artifact when the contrast move from the right ventricle to the left ventricle. Normally lasts for a few heartbeats and vary temporarily as the contrast bolus passes through the left ventricle blood pool, while a real perfusion defect tends to be visible for a longer duration of the imaging. As a conclusion, CMR is emerging as a highly sensitive and specific test for myocardial ischemia and infarction. And stress CMR is non-invasive one-stop assessment of myocardial ischemia, myocardial viability, and cardiac function. Thank you for your attention. I turn back the time to the moderator. Thank you.
Well, thank you, Dr. Mira, for your great presentation. So, ladies and gentlemen, Dr. Mira has emphasized on the basic concept of stress and rest imaging, of perfusion imaging for cardiac, and she also emphasized on image assessment and the content of cardiac MR perfusion report. So, thank you once again for Dr. Mira for your presentations. So, ladies and gentlemen, that's the end of the presentation session. Let's move on to the next session, which is the Q&A session. Once again, for all participants at home, please drop your questions to our speakers through the chat box or Pigeonhole applications. And for the Q&A sessions, please let me call again our dear presidents and all panelists to join us in this session and to help me moderate with these sessions. So for all the panelists, you can open your mic, and if you have any some points to add up or questions to the speakers, so please let the speakers know. So for the presidents and panelists, do you have any questions?
A very good afternoon. Today, all the three speakers did very well. All the topics covered so nicely. Congratulations to all. So
Thank you,
there is
Mr.
no
Self.
questions. It's a really a nice, good talk. There's a lot of informations.
Thank you, Mr. Selvakumar from India. So for other panelists, do you have any points to add up or any questions before we check on the Pigeonhole app? Maybe any questions from other Zoom meeting room from other countries? Okay, if
Yeah,
there's no
please
question,
open your speaker.
yes, Miss Chai Lai Kwan from Malaysia.
Okay, I'm actually not really, familiar with MR perfusions for cardiac, but I have seen a lot of nuclear medicine perfusions. So I just want to ask whoever out of the three speakers, what decide, patient condition, what will decide to choose which modality? Because all are cardiac patients. So anybody can actually just give me some idea when you decide the patient should go for nuclear medicine or MRI or the other perfusions. Thank you.
Okay, thank you, Miss Chai Lai Kwan from Malaysia. Maybe Dr. Mira or Ibu Devi or Ibu Ari, Miss Ari, can answer the questions. So when the patient should go to the CT or MR or nuclear medicine, so how do we choose the modality?
Okay, thank you for the question. I'll try to answer the question from Miss Chan Lai Kwan. Yeah, for as we know, for case is like a CAD, if the patient has complaint with the unstable chest pain like angina pectoris, yeah, we need to do a CMR, myocardial perfusion to make sure there is inducible ischemic or not, because this very important to decide what the treatment for the patient. It needs revascularization or not. So we have to make sure to do myocardial perfusion. It can be CMR or skin with radionuclear and other stress tests like treadmill test and others. Thank you.
Thank you, Dr. Mila. So how about the answer, Miss Chan Lai Kwan? So Dr. Mila, does it mean that so whether it's CT or MR or nuclear medicine, so all of the modalities has the same output? All are important, yes. Or we can just choose one modality?
Yeah, we can choose a CT or MR perfusion.
Oh, CT or MR. Okay. So Ms. Chan Lai Kwan, do you want to add up?
Thank you. I guess so, because the availability of the modality is important. Even though, because I think not everywhere you can get nuclear medicine. Even though I think it's quite good for cardiac imaging, because it actually show you the viability of the muscle of the heart. But I think not every hospital have that modality. So I think CT and MRI is more easily available.
Yes. Thank you, Mr. Chan Lai Kwan. So it depends again on the accessibility and the availability of the modalities, right? Okay. Thank you, Mr. Chan Lai Kwan. Do you have any more questions from the panelists? Or
hello,
from the president?
I have a question for, first of
Yes.
all, yes, thank you. First of all, allow me to represent the president of FRA, Mr. Tai Van Lộc, to send the press reading to the CES 25 CPD hosted by Indonesia, and hopefully is the conference will success. And second, I have question. It's not totally a question. It's about a discussion to the second and third speaker about depend on the climate or center of your country, but you have many the technique, imagine technique in the cardiovascular disease, especially myocardial ischemia, like MRI, CTA, or coronary intervention, or spacity or bed CT. So which technique do you like it the best for patient in now? Yeah. So yeah, two the second speaker or third speaker can answer. Thank you.
Okay, thank you, Mr. Lu Tri Dong from Vietnam. So the question is directed to the second and third speaker, Ms. Devi and Dr. Mira. Would you like to answer the question?
Sorry, Miss Irma, can you repeat the question? Maybe I lost for the first statement.
Okay, Mr. Lu Tri Dong, can you repeat it once again, the question?
Yes, yes, my discussion or my question is depend on your center, but which one do you think about the best for patient, especially myocardial ischemia patient? MRI, CTA, cardio MR, or CTA, or coronary intervention, or bed CT or bed CT. So which one do you want to think about the best? It's the best. Can you explain?
So maybe Ms. Devi or Dr.
Yes.
Mira. So which modality do you think the best to show or diagnose the ischemic case? Yeah, is it CT, MR, or other modality?
Yes.
Yes.
Okay, I'll try to answer the question. First of all, we have to know the clinics of the patient, and then and absolutely the one who has to choose which one the best modality to this patient with ischemia is the doctor, not me. Absolutely, but each of that modality has sensitivity, and it depends of the doctor which one do they want to choose to to make to know about the ischemia for the patient. But for me, absolutely I will choose MBI.
Yes, yes. Yeah, thank you. Yeah,
Thank
I
you,
think as I know, just depend on the doctor when which one the doctor will choose to do the best for patient. But yeah, I want to depend you. What will you think? Yeah, what you think about for the technologist from a technologist? Yeah.
Yeah. Maybe Dr. Mira, you have a different opinion or want to add some points maybe? Which modality will be best for the patient?
Yeah, I just want to add the information, Mr. Lu, for case of myocardial ischemia in our country, we prefer CMR because with CMR, we not only see the myocardial perfusion, but we can also see the function. We can measure the function of the right and left ventricle, and also assessment for viability of the myocard. There is the myocard is still viable or not. So MRI is still the best choice for the ischemia case. Thank you.
Yes, thank you. I think you too. I also think with you. The cardiac MRI now it's this time it's the best for the patient with myocardial ischemia. Yes, because it's a yeah, many reason, but I also think that MRI is the best. Yeah, thank you very much.
Thank you.
Thank you, Mr. Lu, Tridang, and Dr. Mira and Ms. Devi for the discussions. Yeah. So Dr. Mira goes to MR. Okay. Okay, so any more questions from the panelists or the presidents? If no, Pichi Luna posted a question from Philippines, maybe from the members or from Pichi itself. So she asks how to limit the potential artifacts and how to correct them for Ibu Devi, maybe in nuclear medicine, or Ibu Ari, Miss Ari. Is there any potential artifacts that may rise from nuclear medicine or magnetic resonance imaging, and how to correct them? Maybe Miss Ari, would you like to answer?
Okay. I'd like to try to answer the question. The artifact that often come up at the CMR is a wraparound artifact. There is several ways to reduce wrap artifact. The first is we can increase the field of view. And then the second one is we can add pulsar encoding, or in other machine we call pulsar oversampling or fold over suppression, or in our machine is we call it no pulsar wrap. And the third one, we can swap pulsar and frequency direction. And for the last, maybe if the patient is too big, we can positioning the patient hand over the head if it is possible. I think that's my answer.
Okay, thank you, Miss Ari. Thank you for the answer. So Miss Ari has answered that we may play with the FOV and encoding phase and phase directions. And if the patient is big, we can put their arms above the patients. Yeah. Okay. Any more points to add up, dear presidents and panelists? Okay. Bliputu, can you show us the pigeonhole?
Yes, sure.
So we can see the questions that has been asked from the participants at home.
Yes.
Oh, we have a lot of questions.
Yeah.
Okay, the first one with 3-fold, maybe it is directed to Miss Ari. From Dede. Yeah. Can the patients with heart rhythm abnormalities have MPI and MRI examinations? Miss Ari, would you like to answer that?
Okay, I try to answer the question. Okay. For patient with arrhythmia, we can do several techniques. First of all, we have to know what kind of degree of arrhythmia the patient has. One of the technique that we can do is we can do heart rate or rhythm control before scanning by giving beta blocker or other anti-arrhythmia medication. And the second one, we can use arrhythmia rejection by increase the breath hold time. The other way to use the prospective triggering, it used to reduce the CNR. And the last, we can use real-time imaging by reducing temporal and spatial resolution as well as SNR. Okay, that will be my answer. Thank you, Ms. Irma.
Okay, thank you, Ms. Ari. So, Mr. Dede, so Ms. Ari has answered that we can control the rhythm by giving the patients beta blocker or anti-arrhythmia medications. We can also increase the breath hold time and reducing the resolution, if that's right. Okay. So there are several ways that we can do. So it means that the patients with heart rhythm abnormalities still can have the examination. Thank you for your question, Ms. Dede. And the second question, Bliputu, you can zoom one of them.
Which one?
Okay, maybe, yeah, for Dr. Mira, that's okay.
Okay.
Okay, for Dr. Mila, the question is, which are of those indications in cardiac MR we should do the early gadolinium enhancement sequences? Should we do to all indications or just for specific indication?
Okay, thank you for the question. Early gadolinium enhancement is not routine for ischemic case, but early gadolinium enhancement is the first purpose is to see there is a thrombus or not. So we have to do early gadolinium enhancement. But if the doctor don't want to miss the thrombus, like the small thrombus, better you do AGE in every examination of CMR. Thank you.
Okay, thank you, Dr. Mira. So it's optional, okay, if we want to see the thrombus especially, right? Okay, next, maybe one question maybe for, yeah, Miss Leila. So the question is directed for Miss Laila or Ibu Devi. Are there any other radiopharmaceutical that can be used for MPI procedure? Ibu Devi?
Okay, thank you. If you don't have Mioview or tetraphosphamine, you can change that with Zetamib. Usually we use that if we can get Mioview.
Okay, thank you for the questions, Ibu Devi. So there are other options for the pharmaceutical. Okay. Okay, maybe that one from Khairul Huda. Because all of the speakers are talking about caffeine. Why do we need to avoid caffeine? Yes, for Ibu Leila or Dr. Mira, maybe why before the examinations of nuclear medicines, the patient is not allowed to drink anything that contain caffeine? For Ibu Devi or Dr. Mira?
Okay, I'll try to answer. Caffeine have the same effect with adenosine. So when we do adenosine stress test and the patient has consumed contain caffeine, so the heart rate will not raise as usually. So the adenosine stress test will fail. We cannot do stress test when the patient consume caffeine. That's all. Thank you.
Okay, thank you, Ibu Devi. So it may affect the examination. Yeah, it will fail the stress test. Yeah. Okay. Any more questions? Maybe artifacts from Mr. Ludi already answered by Miss Ari.
Burma.
Yes.
Gatot speaking.
Yes.
I think we need to consider the question number 3 and above. Yeah, I think this is important.
Okay.
Dr. Mira, I think you need to share the idea for the breastfeeding moms, not only for the CMR or MPI, maybe for the iogenic contrast media for the breast mom father, how long they can feeding the babies again after the exam done. Not only for the CMR and MPI, but also the ionic contrast media. Please. Thank you.
Thank you, Mr. Gatot. Good spot. Yeah. So for breastfeeding mothers, how long they can breastfeed again after they got contrast injection? Dr. Mira, would you like to answer?
Yeah. For breastfeeding mother, the contrast media will be washed out after 24 hours after examination. So after that, they can give the breastfeeding. So only 24 hours.
So that is including the ionic contrast media, doctor, for CT or maybe the IVP. Oh, okay, sure.
Yes, same part.
Thank you, doctor.
Thank you, Dr. Mira. Thank you, Pak Gatot. Maybe one more question, please, from caffeine, artifacts, and caffeine again. Beside adolescence. Oh, maybe the questions from Kartik K. Dibli. How to do cardiac MR for low heart rate patients like 50 or 60 BPM? For Dr. Mira, or maybe it's for Ibu Ari, Mbak Ari? If the patient has low heart rate like 50 or 60 BPM, how do we do it for the cardiac MR?
Yeah,
Sorry.
Oh, yeah, it's okay.
It's okay.
Yeah, maybe Dr. Mila first, maybe.
Yeah, this heart rate is the best candidate for cardiac MRI. Yeah? If they have like 60 and under than 60. So it's I think not important issue for this. Maybe Miss Ari can add information.
Okay, Miss Ari, would you like to add some points?
I'd like try to answer. In harapan kita, based on my experience for this kind of patient, we do the CMR with rest perfusion, because for the SINA or for the other sequences it's okay, but for the using adenosine, the doctor usually choose not to use adenosine, but only doing the rest perfusion. I think it's my answer. Thank you.
Okay, Miss Ari, so then the examination will go straight away to rest perfusion if they have low heart rate. Yeah. Okay, any more questions? Or maybe the last questions, please. For Miss Ari and Miss Devi, what should we do in emergency, maybe? Yeah? For example, suddenly the patients cannot breathe or something else during the examination. So I think it's related to emergency response. Would you like to answer, Miss Ari or Miss Devi, based on your experience?
Yeah, I'll try to answer first, maybe before my friends answer for the second step. Usually when we are in emergency condition, I mean code blue at my hospital, we are a team doing this examination. There is a doctor, nurse, radiographer, and we will try to look the best way how to know what really happened to the patient. If the doctor, maybe sometimes the doctor doing CPR, or maybe they have to move the patient to emergency room.
Okay, thank you, Miss Devi, Bu Devi. So code blue immediately and perform the basic life supports and work in a team, right, Miss Devi? Okay, if that's the point. And Miss Ari, would you like to add some points?
No,
based on your
I think it's
experience?
enough. Mr.
Oh,
Devi Miss Devi already answered that. Thank you, Mr.
Okay.
Devi.
Thank you, Miss Ari. So any more questions from the panelists, maybe? Would you like to add some questions, or is there any questions from other countries? You can forward it to our chat box for the team support from other countries. No? Okay. Well, I think if there are no more questions from the panelists or from the participants, I think this marks the end of our Q&A sessions. Thank you so much again for your participations for the participants. And thank you again for all of the speakers, especially Dr. Mila, because we know that you are sick today, but you are committed to present here today. Thank you so much for all the speakers and delegates, the panelists, and the participants for your active participations during the Q&A session. Okay, ladies and gentlemen, this is the end of our scientific sessions. And for the next sessions, I will hand it back to our MC, Pichi Luna, for announcement of the next CPD Asia and for the closing ceremony. Thank you so much. Pichi?
Yes, thank you so much, Ms. Putu Irma Wulandari, our program session moderator. We would like also to say thank you very much to all our presidents and the panelists. The PARI, Perhimpunan Radiographers Indonesia, has just provided us with 3 great speakers who have just shared to us very interesting and important discussions. From CPD Asia, I would like to say thank you, Ari Dwi Jayanti, Leila Nur Divyati, and of course to Dr. Mira Yunyarti. We have learned so much from your very interesting discussions. Now, in the interest of time, we have to cut from here to give way for the closing session. I know we are all excited to know about the next exciting online CPD Asia schedule, and I am more happy to announce that the Philippine Association of Radiologic Technologists Incorporated will host the 26th CPD Asia, and that's happening on June 25, 2023. And please keep updated as we shall be posting more details soon. So in closing, we would like to say big congratulations to Perhimpunan Radiographers Indonesia, or Indonesian Society of Radiographers, or PARI, to President Dr. Giek Sugianto, to all the PARI officers, the organizing committees of the 25th CPD Asia. We give thanks to the support also of our many sponsors, and also to Vietnam, VT Healthcare. We are grateful to our great speakers, and most of all, we are sincerely grateful to all our member societies presidents, to our very hardworking CPD Asia IT team, and to all the registered participants who have made this online CPD Asia program a success. We would like to see you again in the next Asia CPD. Again, I am Pichi Luna, and I say thank you, everyone. Have a great day.
Thank you.
Congratulations, Pichi, for your next CPD program. We are going to conduct. All the best. Thank you, Pari, for making a good program today on MR.
Thank you, sir. See you.
Thank you, Mr. Sokokuma. Thank you,
Bu Hari.
everyone.
Hari, makasih. Mbak Devi, Mbak Laila.
Terima kasih Mbak Ari, Bu Devi, Dr. Mira, sehat-sehat. Ketemu Dok.
Terima kasih Dr. Mira.
Khas boleh.
Happy Sunday to all.
Ya, terima kasih, Dok.
Thank you. See you.
Thank you, Presiden semua.
Bye.
Stay safe, Pichi, and everyone from Philippines.
Yes, yes, thank you.
Bye-bye.
Bye-bye, ma'am.
Thank you,
Madam
Mr. Chan
Laikwan. Thank you.
Thank you, Jessica.
Chairman
you.
Karanang, thank you. Madam Chan Laikwan, thank you.
Thank you, Debbie.
Thank you, Mbak Ari.
Thank you, Pichi. Thank you, everybody. It's so nice. At least we see online once a month.
Yeah.
Thank you, Madam Chan.
Correct, Madam.
See you in Malaysia, Madam Chan
See you in
Laikwan.
Malaysia.
Yeah, we see everybody, even we are in separate country. So this is a good platform. I actually try not to miss anyone. Have a good Sunday. Bye.
Thank you. Thank you, Mbak Putu.
Terima kasih.
Bapak Ibu, pre-test dan post-test itu di post-test sudah ada di kolom chat. Terus kemudian untuk penutupan, Miss Irma, I would like to play us the hymn of PARI as a closing.
Thank you, Bli Putu. Pichi, thank you once again. See you next month.
Yes, thank you again. Thank you, everyone. Thank you, everyone in Indonesia.
You have many fans in Indonesia, Pichi.
Oh, really? Thank you so much.
Yeah.
Wow, thank you so much. I wish I could go back again in Indonesia.
Yeah. Thank you.
Permission
Maybe
to
you
leave
can.
the Zoom. Oh,
Okay. See you.
Okay, see
yeah,
you.
permission to leave the Zoom. Thank you.
Thank you, Pichi. Selamat sore, Pak Rustanto, Pak Arsyan.
Selamat sore, Mbak.
Ya, selamat sore, selamat berdinas.
Ya. Wow. Sangat-sangat exciting ya, Mbak ya. I'm so very exciting to.
Waduh, kok baru keluar Inggrisnya tadi? Harusnya keluarin Inggrisnya. Just now you're exciting.
Yeah.
You should spill
Pak
out your
Madepurwo
excitement.
ini lagi ini bergelantungan, Pak Madepurwo ini ke bawah ini, Pak.
Where is Pak Madepurwo? Where?
Oh, menghilang Pak Madepurwo.
I don't see Pak Madepurwo. Oh iya.
Tadi Pak Madepurwo bergelantungan di
Ya
atas.
tadi Bapak Ibu mohon maaf kelok meetingnya karena banyak ininya Miss Irma banyak kita ngaktifin co-host, jadi nggak tahu siapa co-host yang ngeklikin lock meeting, so tadi meeting sempat kelok, cuman kemudian dibuka. Last tadi ada 323 ya, saya lihat partisipansnya. Kemudian di Zoom yang lagi satu tadi ada sekitar 16-an. Jadi kita aktifkan 2 Zoom yang link, Zoom 1 dan Zoom 2 di sebelah.
Siap, terima kasih ya Beli. Terima kasih Bapak Ibu semuanya atas partisipasinya. Itu Mbak Yulia Devika, terima kasih sudah mantengin dari tadi. Ya, sama-sama Mbak.
Itu yang
Pak Arisa Songko, terima kasih.
Rumah papan itu, Mas.
Salam kenal.
Salam kenal, Mbak Irma.
Ya.
Oke, saya izin untuk memainkan himne PARI sebagai penutup, dan begitu selesai himne PARI maka Zoom akan saya end meeting for all. Bapak Ibu silakan mengisi post-test, dan sebagai syarat ada pre-test, post-test, kemudian nilai 70, waktu join Zoom nanti semuanya akan dikalkulasi. Begitu yang memenuhi syarat akan memperoleh sertifikat 1 SKP. Begitu informasinya. Bu Irma, without further ado, I just following your words. I will play the hymn PARI. And then after hymn PARI end, I will end meeting for all.
Bagi PARI
Oke, izin and meeting for all. Sampai jumpa lagi. Miss Irma, see you tomorrow.
See you tomorrow, Bli.
Oke, sampai gangan dulu nah cara gas dulu nah.
Terima kasih Bapak Ibu.
Ayo.
Pak Rustanto sudah boleh end meeting sekarang. Serius sekali Pak.
Pak D aja ya. Pak D, wes nih. Aja ngopi weh.